So to start off with, we need to go through some terms here. The first term that I want to talk about is end diastolic volume. End diastolic volume can be applied to any chamber in the heart, but what we're interested in is really the left ventricle. And what end diastolic volume means. End diastolic volume, diastole means relaxation. Okay? End diastolic volume simply means what's the amount of blood in a chamber, in our interest, the left ventricle, what's the amount of blood in a chamber at the end of relaxation, right? At the end of diastole. That's when a chamber is filling with blood, right? When it's relaxing. So what we would really say is left ventricular end diastolic volume. What's the amount of blood in the left ventricle when it's finished relaxing? End diastolic volume. At the end of relaxation, diastolic, diastole, what's the volume of blood in the left ventricle? That also means once the left ventricle is finished filling with blood, what's the amount of blood within it? And it tends to be, on average, about 130 milliliters. Okay. That varies significantly from one person to the next, but that's a fair average. Okay, the next term. End systolic volume. Sounds exactly like what it means. End systolic volume means what's the amount of blood in a chamber after it has contracted, right? End systolic volume, systolic, systole. So at the end of systole, at the end of a contraction, what's the volume of blood left within a chamber? Now, what we're usually interested in is left ventricular end systolic volume. What's the amount of blood that's left in the left ventricle after it has contracted, right? After systole. Left ventricular end systolic volume. What's the amount of blood in the left ventricle at the end of systole? After the left ventricle has contracted, end systolic, what's the volume of blood that's left within it? Tends to be about 60 milliliters. Okay. Left ventricular end systolic volume, it's fair to say that it averages about 60 milliliters. That's the amount of blood that's actually left in the left ventricle after it has contracted systole. Okay, now why do we actually want to know these two terms? Because we want to know these two terms to figure out the most important one, which is what's called stroke volume. At least for our interest, it's the most important one. SV, or stroke volume. Stroke volume is a simple definition. It just means what's the amount of blood that a chamber pumps out when it contracts, period. Okay? You can apply this to any chamber, but what's the one that we're interested in? The left ventricle. So what we would say is left ventricular stroke volume. Left ventricular stroke volume means the amount of blood that the left ventricle pumps out when it contracts. How do we figure out left ventricular stroke volume? Well, we use end diastolic volume and end systolic volume. So you say to yourself, I want to know how much blood the left ventricle pumps out when it contracts. So what do? You say, well, first of all, I want to know how much blood was in the left ventricle when it was done relaxing. Right? I want to know the maximum amount of blood that was ever in the left ventricle, right? It's end diastolic volume. At the end of relaxation, at the end of filling, how much blood was in the left ventricle? And we know that was about 130 milliliters. And then you want to say to yourself, okay, well, how much blood was in the left ventricle after it had contracted? When the left ventricle was done contracting, how much blood was left in the left ventricle? We call that end systolic volume, right? At the end of systole, how much blood was left in the left ventricle? And we know that's about 60 milliliters of blood. Okay, the average end systolic volume of the left ventricle, it's fair to say, right, 60 milliliters or so. You know these two values, then you can figure out stroke volume. You know so stroke volume is, first of all, end diastolic volume minus end systolic volume. What you want to do is you want to figure out end diastolic volume. You know that there was 130 milliliters of blood in the left ventricle at the end of relaxation when it was finished filling. And then you know that there was 60 milliliters of blood left in the left ventricle after it finished contracting. 130 milliliters is end diastolic volume, 60 milliliters is end systolic volume. And if you take end diastolic volume, which is 130 milliliters of blood in the left ventricle at the end of relaxation, at the end of filling, and you minus how much blood is left in the left ventricle at the end of contraction, in systolic volume, 60 milliliters, then you figure out stroke volume. It's that simple, right? You take these two values, you take end diastolic volume and you minus end systolic volume from it, and that tells you that the left ventricle pumped out 70 milliliters of blood when it contracted, right? Left ventricular stroke volume in this example is 70 milliliters of blood because you started with 130 milliliters of blood in the left ventricle at the end of relaxation, right? End diastolic volume. That's how much blood is in the left ventricle when it was finished filling. And then after the left ventricle contracted, in systolic volume, there's 60 milliliters of blood left, right? That's in systolic volume. So you take 130, you minus 60, and you figure out, okay, 70 milliliters of blood was pumped out of the left ventricle. That was the left ventricular stroke volume. Incredibly important value to know and to understand where it comes from, right? Now we're going to continue to use this term quite a bit. And where are we going to use this term? In figuring out cardiac output. Cardiac output is the amount of blood being pumped around the body per minute. Okay. Another incredibly important value to know. What's the amount of blood being pumped around the body per minute? And if you want to figure that out, it's quite easy. First of all, you need to know how many times the heart is contracting per minute. We call that heart rate. Let's say that that is approximately, right, 70 times per minute. So you know that the heart is contracting about 70 times per minute because the sinoatrial node fibers are generating about 70 action potentials per minute. Okay? And then you want to know left ventricular stroke volume. And in my example, that was about 70 milliliters. Okay? And what you do is you take heart rate, so you know that the heart is contracting 70 times per minute. And then you know with each contraction, the left ventricle is pumping out 70 milliliters of blood, right? That's the left ventricular stroke volume. And you just take heart rate and you times heart rate by left ventricular stroke volume. And that will tell you how much blood is being pumped around the body per minute. Cardiac output, right? It's only logical. If you know that the heart and thus the left ventricle are contracting 70 times in a minute, and you know that with each contraction, the left ventricle is pumping out 70 milliliters of blood, its stroke volume, then you just take heart rate, 70 beats per minute, times stroke volume, the amount of blood that's being pumped out with each contraction, 70 milliliters, and that will tell you cardiac output, right? That'll tell you how much blood is actually being circulated around the body per minute, right? 70 times 70 is 4,900 milliliters, and we would just say that that's approximately 5 liters. 5 liters is a pretty standard average cardiac output. As I've said a million times, this is going to vary a lot from one person to the next, but that's a normal cardiac output. That's the normal amount of blood that's circulating around a given person's body per minute, right? And it's easy to figure out. You just say how many times is the heart beating per minute, right? That's the heart rate. How many times is the heart contracting per minute? And with each contraction, how much blood is the left ventricle pumping out, right? With each contraction. and then you take heart rate, and you times it by left ventricular stroke volume, and that tells you the amount of blood circulating around the body per minute cardiac output. Okay? Now, we're going to keep talking about cardiac output quite a bit in this lecture. What we want to dedicate our time to is figuring out the things that will influence cardiac output. What will have an effect on cardiac output, the amount of blood circulating around the body per minute? And we know the equation, right? It's heart rate times left ventricular stroke volume. So anything that influences heart rate or left ventricular stroke volume, in most cases both, is going to have a huge impact over cardiac output. If either one of those values increases or decreases, that's going to influence the amount of blood circulating around the body per minute. So on to an incredibly brief description of the autonomic nervous system. This really deserves an entire lecture to itself, at least one, but you're not going to get that. So all I can try to do is just give you a brief overview in a couple minutes. So all I said about the autonomic nervous system, right? It consists of motor neurons. So neurons that travel from the central nervous system through a nerve out towards the periphery. Okay, the autonomic nervous system consists of motor neurons. Okay, and these are motor neurons that are autonomic. We don't have conscious control over them. That's why they're called autonomic. They can be in one of two categories. The autonomic motor neurons can either be sympathetic, cause a fight or flight response, or they can be parasympathetic, cause a rest and digest response. Okay, what this image does is it shows you, first of all, these are all, it's actually what it's showing are nerves, but what travels through our thoracic nerves, there are more neurons than just this that travel through the thoracic nerves, but largely what travel through our thoracic nerves are autonomic motor neurons of the sympathetic category. And it's showing you that these autonomic sympathetic motor neurons, right, travel through our thoracic nerves out to the vast majority of organs in the human body. And when they generate action potentials, they cause a fight or flight response in these organs. Okay? And then over here on the right, these are the more autonomic motor neurons, but they're in the parasympathetic category. Okay? You'll notice that they mostly travel through cranial nerves. Okay? Our parasympathetic autonomic motor neurons mostly travel through our cranial nerves out to the different organs of the human body, and when they generate action potentials, they cause a sort of rest and digest response. And you'll notice that first of all, sympathetic motor neurons, that's how you would typically say it. Most people would just say sympathetic neurons, but to be complete, you'll notice that the sympathetic autonomic motor neurons, nobody would say that, but the sympathetic autonomic motor neurons that travel mostly through our thoracic nerves, right? They travel out to all of the same organs that are parasympathetic autonomic motor neurons that travel through our cranial nerves do. Okay? You'll notice they travel to the exact same organs. Okay? The point is, most organs are innervated, synapse with, both sympathetic autonomic motor neurons that travel through our thoracic nerves and parasympathetic autonomic motor neurons that travel through our cranial nerves. And a great example of that is the heart. So here you have it. Hopefully, seeing that previous image makes this one make a little bit more sense. If it doesn't, I apologize, but that was my goal. So if you look, now we're just looking at one spinal cord. Okay? What must be traveling through these thoracic nerves? Okay? What's traveling through those thoracic nerves? We just went through this. those are sympathetic autonomic motor neurons. And you'll notice that they travel out to the heart. Right? There are thoracic nerves that travel out to the heart, and what travels through those thoracic nerves are sympathetic autonomic motor neurons. And you'll notice that there is a cranial nerve. It's the vagus nerve, travels to all kinds of different organs, but you'll notice that this cranial nerve, it's the 10th pair of cranial nerves, it travels out to the heart. And what travels through this cranial nerve are parasympathetic autonomic motor neurons. Okay? That's what this is showing you. So what it's trying to show you is that both sympathetic autonomic motor neurons travel out to the heart through thoracic nerves, and parasympathetic autonomic motor neurons travel out to the heart through cranial nerves, a cranial nerve. So basically the point is to say the heart can be influenced by both the sympathetic nervous system, the fight or flight system, and the parasympathetic nervous system, the rest and digest system. So the heart is influenced by both of them. And our objective now is to try to figure out what these two different autonomic motor neurons, meaning sympathetic and parasympathetic, would do to the heart. Okay? You'll notice that both the sympathetic autonomic motor neurons synapse with the sinoatrial node and the parasympathetic autonomic motor neurons synapse with the sinoatrial node, right? They both do, right? You see it in green and you see it in this kind of bluish color. That's showing the fact that sympathetic neurons, sympathetic autonomic motor neurons, travel out through thoracic nerves and synapse with the sinoatrial node. And you notice that parasympathetic autonomic motor neurons travel out through a cranial nerve and they synapse with the sinoatrial node. Well, that's interesting. So let's talk about what that must mean. Okay? Before we do that, what I want to say is, what's the neurotransmitter that they release? Okay? What we know about sympathetic neurons, sympathetic autonomic motor neurons, they all release, for the most part, norepinephrine. Norepinephrine is the neurotransmitter of the sympathetic nervous system. We could go back to the prior image. Almost every single one, there's like a very small few exceptions to this rule, but basically every single sympathetic autonomic motor neuron in the human body that you have, when it generates an action potential, it releases norepinephrine from its axon terminal buttons. And the parasympathetic autonomic motor neurons, every single one of them, for the most part, releases ACH, acetylcholine. Acetylcholine is the neurotransmitter of the parasympathetic nervous system, right? Because we know that parasympathetic autonomic motor neurons, really all of them release acetylcholine from their axon terminal buttons. So what you'll oftentimes hear is that norepinephrine is the neurotransmitter of the sympathetic nervous system, and acetylcholine is the neurotransmitter of the parasympathetic nervous system. So, since both sympathetic neurons and parasympathetic neurons synapse with the sinoatrial node, that must mean that there are receptors on the sinoatrial node fibers for both norepinephrine and acetylcholine. Why? Well, because sympathetic neurons synapse with the sinoatrial node, so presumably those sympathetic neurons release norepinephrine onto the sinoatrial node, and parasympathetic neurons synapse with the sinoatrial node, so presumably they release acetylcholine onto the sinoatrial node. So the point is, there's got to be receptors for norepinephrine on the sinoatrial node fibers and for acetylcholine on the sinoatrial node fibers. Okay. Now, before we differentiate between the names of the different receptors and the specific pathways, what they result in, we need to talk about just generically an important G protein pathway. Okay, this is a pathway that you find in almost every single cell in the human body, and this is why something like the autonomic nervous system deserves an entire multiple lectures to itself. But again, you're not getting them, unfortunately, because again, there's not enough time. But it's hard to even explain. But I can promise you, it's hard to explain without time. But I can promise you that this particular pathway, this is called a G protein pathway. These G protein pathways exist. I can't think of any cell in the human body that doesn't have a G protein pathway. There's got to be one, because there's always exceptions to basically every rule. But generally, like every cell, all of the cells you have in your body have some sort of G protein pathway. Okay? And this is one of the most common G protein pathways. So what happens with this G protein pathway? First of all, you have a receptor on the cell. Okay? You have a receptor on the cell, and then a chemical messenger will come along and it'll bind to the receptor. The chemical messenger could be acetylcholine, it could be norepinephrine, it could be countless other chemical messengers too. You know, if you go into like pharmacology or something, you could spend years talking about how all of the different chemical messengers can bind to G protein pathways and then what the pathways do. Okay, so we got to keep this as simple as possible. The cell, in this case the sinyl-HL node fiber, has a receptor on its plasma membrane. You have to assume that this is the plasma membrane of the SA node fiber. Okay, this is the plasma membrane of the SA node fiber. And within the plasma membrane of this SA node fiber, there is a receptor. And what can bind to that receptor is clearly a chemical messenger. In this case, we're keeping it as simple as possible. So really, it could either be acetylcholine or it could be norepinephrine. We'll differentiate about those in just a second. But the chemical messenger, whatever it is binding to the receptor. And then on the inside, the intracellular side, bound to the receptor are three proteins, three subunits as they're called. There's the alpha subunit, the beta subunit, and the gamma subunit. Okay? When the chemical messenger binds to the receptor, on the intracellular side, you'll notice that the alpha, beta, and gamma subunit are attached to the receptor, the integral protein as it would be referred to. And what will happen is the alpha subunit will swap out GDP, guanine diphosphate that's attached to it, and it'll swap out GDP for GTP, as is being depicted here. Okay, so the alpha subunit will swap out GDP, let's go like this, for GTP. Okay. The alpha subunit will now have GTP bound to it, guanine triphosphate. Okay. This is what happens when the chemical messenger actually binds to the receptor. It causes the alpha subunit to swap out GDP for GTP. And then once the alpha subunit has swapped out GDP for GTP, what will happen is the alpha subunit will dissociate away from the beta and the gamma subunit. It'll leave it behind. And it'll start crawling. I wish it would go in the opposite direction, or at least have the subunits flipped around. But what'll happen is the alpha subunit, when it swaps out GDP for GTP, it'll dissociate away from the beta and the gamma subunit. It'll move away from them, and it'll start crawling along the intracellular side of the membrane until it finds this enzyme, which is called adenylate or adenyl cyclase. And when the alpha subunit binds to adenylate cyclase, this enzyme, which is actually another integral protein, it's a transmembrane protein. It exists in the plasma membrane, but it's an enzyme. Okay, so the alpha subunit will bind to adenylate cyclase, and it'll actually activate adenylate cyclase. And then what adenylate cyclase will start to do? Adenylate cyclase is an enzyme. It'll start converting adenosine triphosphate, ATP, into cyclic or cyclic AMP. This is one of these chemical messaging nucleotides that we talked about at the very, very beginning of the semester. Cyclic AMP, how you make it is you strip two phosphates off of the ATP. And if you strip two phosphates off of the ATP, then you get AMP, adenosine monophosphate, right? An adenine with two phosphates, excuse me, adenosine with two phosphates attached to it. If you take one phosphate away from ATP, then you get ADP, right? Adenosine diphosphate. If you take the second phosphate away and you only have one phosphate left, then you have adenosine monophosphate, right? Adenosine with one phosphate. Okay. And then what you do is you bind the phosphate to the sugar, and it creates a ring, and it gets called cyclic or cyclic AMP, depending upon how the person likes to pronounce it. Okay. That's what adenylate cyclase does. It takes ATP and it turns ATP into cyclic AMP. Okay. And cyclic AMP is what's called the second messenger. Cyclic AMP is the second messenger of this whole process is called the G protein pathway, but cyclic AMP is the second messenger of this cyclic AMP pathway. Excuse me, cyclic AMP is the second messenger of this G protein pathway. This particular G protein pathway is often called just simply a cyclic AMP pathway. People that study this, if you say the cyclic AMP pathway, they'll know this is exactly what you're talking about. And you could do the same thing. It's just that there's actually multiple different G protein pathways. And so some of them will call it the IP3 or the DAG pathway. It's a G protein pathway. This is just one of them. This is the most common. It's the cyclic AMP G protein pathway. This whole thing is a G protein pathway. But the specific G protein pathway that we're talking about is the cyclic AMP G protein pathway. Cyclic AMP is the second messenger. Okay, so what does cyclic AMP do? Those are probably things maybe you don't care about or even want to know. So what happens with cyclic AMP? Cyclic AMP, what it'll do is it'll go along and it'll bind to and activate what are called kinases, protein kinases. Cyclic AMP specifically tends to activate what's called protein kinase A, which is another intracellular enzyme. Cyclic AMP will bind to protein kinase A and activate it. And what protein kinase A does, well, protein kinases are enzymes that phosphorylate things. So if protein kinase A is activated, then what protein kinase A will start to do is it'll start going around intracellularly and it'll start phosphorylating things. And that's exactly what's going to happen in the cyclic AMP pathways. If the cyclic AMP pathway is activate. Now there can be vast differences in what protein kinase A will do in one cell to the next, but if a cyclic AMP pathway, G protein pathway, is activated, you can assume what will arise inside of the cell is protein kinase A, because cyclic AMP will activate protein kinase A. And then what protein kinase A will do is it'll start phosphorylating things. And that's where the differences start coming about. Because you're not really going to see that with this specific example, but from one cell to the next, the protein kinase A can phosphorylate and do very different things from one cell to another. I realize we're only talking about the sinoatrial node, so let's try to keep on, by let's, I mean me. Let's try to keep track here and on the correct path. All I wanted you to see here was the pathway. That was it. I wanted you to see this specific G protein pathway. This is a G protein pathway. Specifically, it's called a cyclic AMP G protein pathway. And when this pathway is activated, cyclic AMP will increase the amount of protein kinase A inside of the cell, which will start phosphorylating things. So let's get back now to the conversation of the sympathetic versus the parasympathetic nervous system and the influence that it will have over the sinoatrial node. So let's start off talking about the sympathetic nervous system. What happens? Like, what's going to get the sympathetic nervous system going? Psychologically, usually to get the sympathetic nervous system going, the person, for one, could be getting ready to engage in exercise or actively engaging in exercise. It doesn't have to be exercise. Let's just call it physical activity, right? Running from one class to the next would be a type of physical activity. If you want to get into a semantical argument and not call that exercise, that's fine. The person is running from one course to the next, right? That's physical activity. It could also just be beyond physical activity. that's really where if you think of the evolution of the fight or flight system, that's what it's for, fighting or running away from another animal, presumably a predator. Okay, so what the fight or flight system is doing is preparing the person to engage in physical activity. So when you're getting ready or are engaging in physical activity, these sympathetic autonomic motor neurons, they start generating action potentials. Now, at the same time, anything that makes somebody really anxious or excited can definitely does activate the sympathetic nervous system too. Okay? But if we think about like the, historical physiological evolutionary value to the sympathetic nervous system, it is definitely to engage in physical activity, right? That's its predominant role. So again, we'll say, okay, the person is getting ready or is engaging in some form of physical activity, right? They're lifting up a table, they are sprinting from one course to the next, sprinting to a bus, I don't know. They're engaging in physical activity. And when they're engaging in that physical activity, what's going to start happening is these sympathetic autonomic motor neurons are going to start generating action potentials. And we know that some of them travel out through thoracic nerves and synapse with the sinoatrial node. So when they generate action potentials, they release norepinephrine from their axon terminal buttons onto the sinoatrial node. And we want to know, what effect is norepinephrine going to have on these sinoatrial node fibers? Because these sympathetic neurons, these sympathetic autonomic motor neurons, are releasing norepinephrine onto the sinoatrial node when this person is engaging or getting ready to engage in some form of physical activity. So yet again, here's the plasma membrane of an SA node fiber. Here is a sympathetic autonomic motor neuron releasing norepinephrine onto the sinoatrial node fiber. Okay, you also see that it says epinephrine, but epinephrine is a hormone which would also be circulating around in the bloodstream during a sympathetic response, kind of a fight or flight situation, but that's not what we're talking about. We're talking about norepinephrine. So this sympathetic autonomic motor neuron is releasing norepinephrine from its axon terminal buttons. Okay, and it's releasing norepinephrine onto this sinoatrial node fiber of the heart. Okay, embedded into the plasma membrane of this sinoatrial node fiber are receptors for norepinephrine. Okay, that's the receptor right there. They're called adrenergic receptors. That stands for adrenaline receptors. Norepinephrine and epinephrine can also be called adrenaline. Okay, so the name of the receptor it's named after adrenaline. These are adrenergic receptors. There are different types of adrenergic receptors on different cells of the body, but this is one type of adrenergic receptor. We find these adrenergic receptors located on sinoatrial node fibers. Okay? So what's going to happen, you think? Well, norepinephrine is clearly going to bind to these adrenergic receptors because these adrenergic receptors are designed to bind norepinephrine. And these adrenergic receptors that bind norepinephrine, they cause intracellularly a G protein pathway to occur. Another way of saying that, maybe more simply, is that when norepinephrine that's released from the sympathetic autonomic motor neuron, when norepinephrine binds to this adrenergic receptor on the sinoatrial node fiber, that will activate intracellularly a G protein pathway, specifically a cyclic AMP G protein pathway. So when norepinephrine binds to the adrenergic receptor, look at here. Here on the inside, there are the different subunits. The alpha subunit will swap out GDP for GTP. Then the alpha subunit will dissociate away from the beta and the gamma, travel along the intracellular side of the membrane, activate adenylate cyclase, which will start converting ATP into cyclic AMP. Cyclic AMP is the second messenger of the G protein pathway, and then it will start activating protein kinase A, oftentimes abbreviated pKa, protein kinase A. So let's think about this. Downstream, meaning downstream of the pathway, downstream, when norepinephrine is released onto a sinylateral node fiber, and norepinephrine binds to the adrenergic receptor on the sinylateral node fiber. Downstream, what will increase is pKa, protein kinase A, thanks to cyclic AMP due to the G protein pathway. Okay, so inside of this sinylateral node fiber, protein kinase A is elevated thanks to norepinephrine binding to adrenergic receptors located on the sinylateral node fiber. pKa is elevated in these sinylateral node fibers right now. And the question is, what is protein kinase A going to do? And what protein kinase A will do is it will travel over to funny channels and probably calcium channels as well. And what pKa will do is it will start phosphorylating the funny channels and these calcium channels. Protein kinase A, pKa, is a kinase, so it phosphorylates things. And inside of the sinylateral node fibers, pKa will start phosphorylating funny channels, as well as, we don't understand this part quite as well, but calcium channels as well. To really talk about the calcium channels, you have to get into a theoretical conversation that goes beyond the scope of this course. So we will just focus on the funny channels, okay? When pKa phosphorylates the funny channels, those are voltage-gated sodium channels, right? What it does to them, at least what we theorize it does to them, is it causes basically more to be open at a given time, okay? There are funny channels that don't open up, let's say, until the SA node fiber were to get to -61 or -62 or -63. There are not all the funny channels open up at -60. That's the point. Okay? You're going to see why that's necessary in a moment, I promise, when we get to the parasympathetic nervous system. But not all funny channels open up at -60. Actually, some of them start opening up at like -58, -59. Most of them are going to open up around -60, but some don't open up until the interior becomes even more negative than that. So the point is, in a like normal functioning heart, like, you know, when the heart rate is 70 beats per minute, and the peak negative potential of the SA node fiber is, you know, it only gets to -60. There's a lot of funny channels that just never actually even open, because it doesn't get negative enough for a lot of the funny channels to open. But what will happen is, if pKa starts phosphorylating certain funny channels, it'll cause them to open up at more positive potentials, basically. Okay? If you don't want to kind of comprehend or try to understand any of that, it's okay, because you could just realize basically what will happen is at -60, there will be a lot more funny channels open than there typically is. Okay? That's the point. What pKa will do is it'll phosphorylate some funny channels. It'll basically sensitize them. And what that does is it causes more funny channels to be open at -60 than would typically be open at -60. That's what the sympathetic nervous system is going to do to these sinylateral node fibers. It's going to accomplish that by releasing norepinephrine onto these sinylateral node fibers. Norepinephrine will bind to receptors on the sinylateral node fibers called adrenergic receptors that bind norepinephrine. And when norepinephrine binds to these adrenergic receptors, it activates this cyclic AMPG protein pathway inside of the SA node fiber, which downstream causes pKa, protein kinase A, levels to rise. And then pKa will phosphorylate funny channels inside, attached to the plasma membrane, embedded in the plasma membrane of the SA node fibers. And what you'll get is more funny channels open at -60 than typical. What effect is this going to have on the sinoatrial node fibers. In gray, I'll draw it in red, right? In gray, this is how long it typically takes the sinoatrial node fibers to get to threshold, right? From approximately -60 to -50. This is how long it usually takes. You know, the funny channels open up, sodium comes in, drives the interior to threshold, and then when you get to threshold, all the voltage-gated calcium channels, the L-type calcium channels open, and you get an action potential, okay? That propagates down the SA node fiber and then into the contractile fibers, okay? Then the repolarization process happens, right? And the process repeats. I'm not going to go back through the whole depolarization, action potential, repolarization process with you, right? If you need to do that, by all means, go back to prior lectures, okay? But what this is showing you is it's repolarization of the sinoatrial node fiber, and then it starts depolarizing again, right? Why does it start depolarizing again? Because the voltage-gated potassium channels close as the interior becomes negative, more and more funny channels open up, and the membrane starts to depolarize again, and this is how long it takes to get to threshold. All right, now, under a sympathetic stimulus, meaning that when sympathetic neurons are releasing norepinephrine onto sinoatrial node fibers, and that norepinephrine is binding to adrenergic receptors, activating the G protein pathway, causing pKa to rise inside and more funny channels to be open than normal inside of the SA node fiber. If more funny channels are open than normal, what is going to be coming in to the SA node fibers at a greater rate than normal? Sodium, right? If there's more funny channels open than there normally is, those are sodium channels. pKa phosphorylates funny channels and causes more to be open than typical. So if you have more funny channels open, then the SA node fiber is more permeable to sodium than it normally would be. And that causes sodium to come in at a greater rate. We know that's what increasing the permeability of a cell to a particular ion, that's what happens, right? If more sodium channels open up, the more sodium channels that are open, the greater the rate that sodium will come in. And if sodium is coming in at a greater rate, what's that going to do? It's going to depolarize the SA node faster. The SA node fiber is going to get to threshold faster because there's more sodium coming in than normal at -60 compared, again, to what's typically happening. There's more funny channels. There's more sodium channels open at -60 than normal. So sodium is shooting in at a greater rate than normal, depolarizing the SA node fiber to threshold faster. You see this in green? In green, that's when the SA node fiber is under a sympathetic stimulus, like when norepinephrine is being released onto it. It gets to threshold way faster than it normally does in gray. And if it gets to threshold faster, what does that mean? If the SA node fiber gets to threshold faster than it typically does, it's going to generate more action potentials over the course of time. Of course, like if the SA node fiber has more sodium channels open than normal, more funny channels open than normal, and sodium is coming in at a greater rate than it typically is, the SA node fiber is going to depolarize to threshold faster, and that's going to happen every single time. As long as the SA node fiber is under a sympathetic stimulus, it's going to keep depolarizing to threshold faster than it normally does, and it's just going to generate more frequent action potentials. Over the course of time, the sympathetic, over the course of time, the SA node fiber, rather than generating 70 action potentials per minute, might generate 100 action potentials per minute. And it's because of the fact that it's getting to threshold faster. Every single time, and then this is where it ends, right? Every single time that the sinoatrial node fibers generate an action potential, what happens? The whole heart contracts. So if the sinoatrial node fibers start generating 100 action potentials per minute, the whole heart's going to contract 100 times per minute. We call that a heart rate of 100. What the sympathetic nervous system does to your heart is it causes your heart rate to increase, right? I think everybody knows this, right? You know, when you're engaging in physical activity, when you're anxious, when you're scared, your heart rate goes up. But your heart rate is going up because of this physiological mechanism. Under that psychological experience of, you know, being in a situation where you're exercising, where you're scared, where you're anxious, you're running, whatever it is, that causes sympathetic neurons to generate action potentials and release norepinephrine onto the sinoatrial node fibers of your heart. And that norepinephrine activates a cyclic AMP G protein pathway by binding to adrenergic receptors on the SA node fibers, which causes pKa to increase and more sodium channels to be open than normal, more funny channels. And your SA node fibers, they start getting to threshold faster. And they generate more action potentials over the course of a minute. And we say that, the way that we say it is, well, your heart rate increases. And it's all because of the fact that your sinoatrial node fibers start generating more frequent action potentials. And you might have the question of like, well, how much will heart rate increase? And that's the question. I mean, to answer that, you have to say, well, how anxious is the person? What's the intensity of physical activity that they're engaging in? Because we know as somebody becomes more anxious, more scared, engaging in more intense physical activity, what happens is the sympathetic neurons, they start generating more frequent action potentials, and they start releasing more norepinephrine onto the sinoatrial node. More epinephrine, this goes back to chemical messengers. If you release more chemical messenger onto a specific cell, like the sinoatrial node fibers, then more norepinephrine will bind to more receptors. Then more pathways will be activated. You'll get more cyclic AMP and pKa that will increase inside of the SA node fibers. More sodium channels will open. You'll get to threshold even faster, and heart rate will increase to an even greater degree. That's why with low intensity exercise, physical activity, your heart rate may only go from 70 to 100. But with really high intensity exercise, it could go up to 200, right? You can get much, much higher, right? Heart rate when you're sprinting is substantially higher than when you're just kind of jogging. And that's because of the fact that these sympathetic neurons are firing at higher frequencies and releasing more norepinephrine, which is activating the pathways to greater degrees inside of the SA node fibers, right? Greater degrees may not be the greatest way of saying it, right? If you release more norepinephrine onto these sinoatrial node fibers, then more norepinephrine will bind to more receptors, which will cause more G protein pathways to be activated, and more pKa will be elevated, and thus more funny channels will be opened. So you'll get to threshold even faster, and you'll have an even greater frequency of action potentials, and heart rate will be even higher. So how much heart rate increases is proportional to the firing frequency of these sympathetic neurons, which is going to be proportional to the intensity of exercise or how anxious the person is. Okay, so it's not that complicated actually. Physiologically, it's somewhat complicated, but you would think, obviously, you know, if somebody is really anxious, the sympathetic neurons are going to be firing at much higher frequencies than if they were just a little bit anxious. So what about the parasympathetic nervous system? Okay. What happens with the parasympathetic? First of all, under what circumstance are these parasympathetic neurons going to start generating action potentials? Well, these parasympathetic autonomic motor neurons will start generating action potentials when a person is relaxed. Okay, the parasympathetic nervous system causes kind of rest and digest. So if the person is relaxed, calm, happy, we could say, you know, I'm no psychologist, but let's, you know, whatever emotion that might be, right, in a good mood, we can assume that mostly the parasympathetic nervous system is going to be more active, certainly when you're getting ready for bed, right, and you're relaxed. These parasympathetic autonomic motor neurons are going to start generating action potentials under these circumstances. And we know that some of these parasympathetic autonomic motor neurons travel out through some of our cranial nerves, namely the vagus nerve, out to the heart, specifically to the sinoatrial node. And what does it do? It releases acetylcholine onto the heart. All parasympathetic, let's say almost all parasympathetic autonomic motor neurons, when they generate action potentials, they release acetylcholine. So now what's happening under this situation where the person is relaxed is their parasympathetic autonomic neurons, autonomic motor neurons, are generating action potentials. And they're releasing then acetylcholine from their axon terminal buttons, and in this case, the acetylcholine is being released onto the sinoatrial node fibers. So what's that going to do? Here you can imagine this is a parasympathetic autonomic motor neuron. The person is relaxed, so this parasympathetic autonomic motor neuron is generating action potentials. And what's it doing? It's releasing acetylcholine from its axon terminal buttons, and acetylcholine is now being released onto the sinoatrial node fibers. This is the plasma membrane of a sinoatrial node fiber. And what you'll notice within the plasma membrane of the sinoatrial node fiber, there are receptors for acetylcholine. Receptors for acetylcholine, first of all, always one way or another, are called cholinergic receptors. Okay. One cholinergic receptor that I showed you is on skeletal muscle fibers. We call that nicotinic cholinergic receptors. The cholinergic receptors, acetylcholine receptors, located on SA node fibers, are called muscarinic cholinergic receptors. They were discovered using this gas, which is called muscarine, and that's what they, that's how they got their name. Muscarinic cholinergic receptors are just another type of acetylcholine receptor, and they're located on your sinoatrial node fibers. So that tells us that our sinoatrial node fibers have the capacity to bind acetylcholine, obviously. Okay, and on the inside, you actually find a G protein pathway. Okay, you see here's the alpha subunit, the beta, and the gamma subunit. It's all there. The alpha subunit has GDP bound to it, and it can swap out GDP for GTP. The whole pathway is there. Okay, so what's going to happen? Well, if the person is relaxed, the parasympathetic autonomic motor neurons will start generating action potentials, and they'll start releasing acetylcholine onto the sinoatrial node fibers. Acetylcholine will bind to acetylcholine receptors located on these sinoatrial node fibers, and that will activate the G protein pathway inside. The alpha subunit will swap out GDP for GTP. It'll dissociate away from the beta and the gamma. But here's the interesting thing. In this pathway, this kind of parasympathetic pathway with regard to the SA node fibers, it's actually the beta and the gamma subunit that appear to be the important ones. So yes, you can see that the alpha subunit swapped out GDP for GTP, dissociated away from the beta and the gamma, but it looks like the beta and the gamma subunit are the ones that are important. The beta and the gamma subunit crawl along the intracellular side of the plasma membrane of the SA node fiber, right? This is an SA node fiber. I think I've said it 10 times, but I'll say it again. And the beta and the gamma subunit, what they do is they travel along the intracellular side and they start phosphorylating and opening potassium channels. And this is actually a specialized type of potassium channel. They're called GERK channels. And they only open up under a parasympathetic response. Basically, this G protein pathway is the only thing that can open them. There's probably other pathways that can do it too, but this is the predominant one. Okay. The beta and the gamma subunit will go over to these things called GERK channels, and it'll start opening them. Right? And what are you accomplishing here? You're making the SA node fiber more permeable to potassium by opening more potassium channels. What let's say this differently. What the parasympathetic nervous system does to the sinoatrial node fibers is it releases acetylcholine onto the sinoatrial node fibers. And acetylcholine binds to the acetylcholine receptors on the sinoatrial node fibers, activating a G protein pathway. And that G protein pathway through the beta and the gamma subunits opens up extra potassium channels within the plasma membrane of the SA node fibers. So another way of saying this is the parasympathetic nervous system, the main thing that it does is it increases the potassium permeability of our SA node fibers. And then you have to think, well, what's that going to do? What would increasing the potassium permeability of our SA node fibers accomplish? All right, so imagine this. This is the plasma membrane. Usually, what starts the depolarization of the SA node fiber at -60? Okay, at -60, what's happening? The voltage-gated potassium channels are closing. They're closing. And at the same time, the funny channels, the F-type channels, are opening. Okay, this is happening at -60. So what happens at -60 is you get to this point where more sodium is coming in than potassium is leaving, and the SA node fiber begins to depolarize, right? It begins to head towards threshold. Okay, but what if there was more potassium channels open than typical? Because that's what the parasympathetic nervous system accomplishes. When the parasympathetic nervous system is activated, right, the parasympathetic neurons are generating action potentials, releasing acetylcholine onto the SA node fibers. And that acetylcholine binds to acetylcholine cholinergic, muscarinic cholinergic receptors. And that G protein pathway actually opens up more potassium channels than normal. So what would happen at -60 under a parasympathetic stimulus? The SA node fiber is being influenced by the parasympathetic nervous system. Thus, there are more potassium channels open than typical. So would the membrane potential reverse at -60? The answer to that is obviously no, right? Because at -60, under a parasympathetic stimulus, let's draw them in red, there would be too many potassium channels still open, GERK channels as we call them. They're open. So at -60, potassium is actually still leaving at a greater rate than sodium is coming in. I'm not saying that these funny channels aren't opening up at -60, because they are. But the problem is, at -60 right now, there's still too many potassium channels open. So let's say at -60, there's still more potassium leaving than sodium coming in through the F-type funny channels. So what's going to happen? The membrane potential is just going to keep depolarizing more and more, negatively. Right? It's going to hyperpolarize. And, it could go from -61, -62, -63. It's under a parasympathetic stimulus. At -60, there's still too many potassium channels open, so potassium continues to leave at a greater rate than sodium comes in through the funny channels. And the membrane potential, it continues to become more and more negative. And here's what will happen, and this is the part about the funny channels. As the interior becomes more and more negative, right? -61, 62, 63, 64, 65, right? As it becomes more and more negative, more and more funny channels will open, kind of dormant funny channels. There are lots of funny channels that open up at much more negative potentials than -60. There are funny channels that don't open up until you get to -70. Okay, so as the interior becomes more and more negative, more and more funny channels will open. And at the same time, we can assume some more and more of the voltage-gated potassium channels will still be closing. Okay, because not all of the voltage-gated potassium channels exactly close probably at -60 either. Again, this becomes so theoretical, but let's just stick with this. As the interior becomes more and more negative, more and more of these funny channels will open, right? Because they open up, they're called funny channels because they open up as the interior becomes more and more negative. So as the interior becomes more and more negative, more and more of them open up, and eventually you'll get to the point where more sodium is coming in than potassium is going out, and the interior will begin to depolarize. You can see over here, this in blue is the SA node fiber under a parasympathetic stimulus. You'll notice that it gets a lot more negative than it typically does. Right? It goes down to around -70, approximately, even a little bit more negative in this image. And that's because of all those extra open potassium channels, right? All those extra open potassium channels means the membrane potential doesn't start reversing at -60. At -60, still more potassium is leaving than sodium is coming in, so it just keeps becoming more negative. And then eventually you get to a point where enough funny channels open that more sodium is coming in than potassium is going out, and you slowly then begin to depolarize towards threshold. But what do you have to do? To get to threshold now, you have to get all the way from -70 to -50 rather than from -60 to -50. So it takes a much longer period of time to go up, it takes much longer to get to threshold if you need to bring up the membrane potential by 20 millivolts compared to 10 millivolts, because usually you have to get the membrane potential from -60 to approximately -50. But now in this example, we have to actually get from -70 or less or even more negative, from -70 to -50, which is 20 millivolts more positive. Obviously, it takes a lot longer to get from -70 to -50 than it takes to get from -60 to -50. And there are probably other factors at play here as well, okay? All in all, what does this mean? It takes a lot longer to get to threshold under a parasympathetic stimulus than normal, okay? Much longer. And beyond just taking longer to get to threshold, you also have to think during the repolarization process, the whole repolarization process lasts longer too, because the interior becomes more negative. It's a much more time-consuming process to actually generate an action potential. But let's keep it as simple as possible. Under a parasympathetic stimulus, the SA node fibers take way longer to get to threshold than they normally do. And you can see in blue here, over the entire time span here, there's only one action potential that gets generated. If it takes way longer to get to threshold than normal, then the SA node fibers are going to generate a much lower frequency of action potentials over the course of a minute. Every action potential translates into a total heart contraction. So what does that tell us about the SA node fibers? Under a parasympathetic stimulus, they'll generate a much lower frequency of action potentials, and thus heart rate will be significantly lower. If the SA node fibers only generate 50 action potentials per minute, then heart rate is only going to be 50 beats, 50 total heart contractions per minute. This is what the parasympathetic nervous system does to our heart rate, right? It slows it down. And again, that, to some degree, that's obvious. You might say, well, I know the parasympathetic nervous system slows my heart rate down, but this is the physiological explanation for how it happens, right? It increases the potassium permeability of the SA node fibers and causes them to take way longer to get to threshold, which translates into a much lower frequency of action potentials and thus a much lower frequency of total heart contractions. So now we can get back to the actual point of all this, which was to talk about the things that influence cardiac output. Cardiac output is the amount of blood circulating around the body per minute. How do we figure it out? Well, we need to know heart rate. How many times is the heart contracting per minute? And we need to know stroke volume, right? What's the amount of blood, left ventricular in particular, what's the amount of blood that's being pumped out of the left ventricle with each contraction? On average, a person's heart beats 70 times per minute. And with each contraction, the left ventricle pumps out 70 milliliters of blood. So you say, okay, I'm going to take heart rate, how many times the heart is beating per minute, and times it by the amount of blood that's being pumped out of the left ventricle with each beat, called the stroke volume, right? Heart rate times stroke volume equals cardiac output. We know that that's approximately 5 liters. So what influence is the sympathetic nervous system going to have over cardiac output? Well, right off the bat, you can see the sympathetic nervous system is going to cause heart rate to rise. Let's say that it causes heart rate to go up to 100. Now, if the heart is beating 100 times per minute, if the heart's beating 100 times per minute and the left ventricle is still pumping out 70 milliliters of blood with each contraction, if the left ventricular stroke volume is still 70 milliliters, then what's going to happen to cardiac output? Well, cardiac output's going to go way up because now the left ventricle is still pumping out 70 milliliters of blood, but it's doing that 100 times over the course of a minute rather than 70 times over the course of a minute. So, of course, cardiac output, the amount of blood circulating around the body, is going to significantly increase under a sympathetic response just because of the fact that heart rate increases. Now, under a parasympathetic response, let's say that heart rate falls to 60 beats per minute. Okay, well now if the heart is only beating 60 times per minute, and let's say that the stroke volume of the left ventricle stays at 70 milliliters, well, compared to a normal situation, like if this is an extreme parasympathetic response, the parasympathetic nervous system is going to cause heart rate to fall. And let's pretend that stroke volume doesn't change, even though it will. Let's pretend stroke volume doesn't change. Now the heart is beating 60 times per minute. The heart is contracting 60 times per minute. And the left ventricle is pumping out 70 milliliters of blood with each contraction. So 60 times 70, that means that cardiac output has actually decreased. So the parasympathetic nervous system will cause cardiac output to fall for one obvious reason, which is it'll cause heart rate to decrease by, of course, making the sinoatrial node generate a lower frequency of action potentials because of the increased potassium permeability. So the general rule is the sympathetic nervous system will increase cardiac output, how much blood is circulating around your body per minute, and the parasympathetic nervous system will decrease cardiac output, the amount of blood circulating around your body per minute. And the main way that it does it, for the conversation we're having right now, is by increasing or decreasing heart rate. But the thing is, the sympathetic nervous system doesn't just influence heart rate. The sympathetic nervous system can have a significant influence over stroke volume, which is part of the cardiac output equation. So, yes, we know that the sympathetic nervous system causes cardiac output to rise. How does it do that? Well, one, it just increases heart rate. If the heart's beating more times per minute and stroke volume stays exactly the same, that alone is, of course, going to cause the amount of blood that's circulating around the body per minute to increase. But it also does some other things that influence stroke volume. And then there are other factors which can increase or decrease stroke volume that we need to talk about as well. But let's start with the sympathetic nervous system. What you'll notice about sympathetic autonomic motor neurons is they don't just travel out to the sinoatrial node, they also travel out to ventricular muscle. So sympathetic neurons also travel out to ventricular muscle fibers, ventricular cardiac muscle fibers, and they release norepinephrine onto these ventricular contractile fibers. And you say, well, what effect is norepinephrine being released onto ventricular contractile fibers going to have? So norepinephrine can actually have a magnitude of effects. We'll try to go through the, let's say the most obvious ones. All right, so here's the plasma membrane of a ventricular contractile cardiac fiber. Okay. What do we notice is located on the plasma membrane of this ventricular contractile fiber? Well, there are adrenergic receptors. There are adrenergic receptors embedded into the plasma membranes of ventricular contractile fibers. And what do we know can be released onto them? Well, we know that sympathetic autonomic motor neurons release norepinephrine onto ventricular contractile fibers. And that norepinephrine can bind to the adrenergic receptors located on the ventricular contractile fibers. And what do you know? Inside, there's a G protein pathway. So when norepinephrine binds to the adrenergic receptors located on these ventricular contractile fibers, it activates a G protein pathway. The alpha subunit swaps out GDP for GTP. crawls along the intracellular side of the plasma membrane, activates adenylate cyclase, ATP is converted into a cyclic AMP. So this is a cyclic AMP G protein pathway, exactly like you've seen before. Okay, but now this is in a contractile ventricular fiber. And what cyclic AMP does is, of course, it activates protein kinase A, pKa. So now pKa levels have increased inside of this ventricular contractile fiber thanks to the sympathetic nervous system, sympathetic neurons releasing norepinephrine onto it. And what does pKa do? The major things that I would ask you about is pKa goes over and it can phosphorylate L-type calcium channels and ryanodine receptors. Okay? L-type calcium channels in the plasma membrane and ryanodine receptors located on the sarcoplasmic reticulum. And what this does is it augments the opening of both. Okay? Let's say this. What do we know about ventricular contractile fibers? Okay. As they propagate their action potentials, what do they use? Voltage-gated sodium channels and voltage-gated calcium channels called L-type channels. Okay. What pKa we think can do is it can phosphorylate calcium channels, and it will cause more of them to be open in the plasma membrane than typical. So basically, as the action potential propagates down the plasma membrane of this ventricular contractile fiber, more voltage-gated calcium channels will be open than typical. Or it has some influence over the calcium channels themselves, which allows them to kind of allow more calcium in than they normally would. Some of it, again, is theoretical. No matter how you look at it, what's that going to do? It's going to allow more calcium into the contractile ventricular fiber than normal, right? Because if pKa phosphorylates and, let's say, causes more voltage-gated calcium channels to be open throughout the plasma membrane than typically would be as the action potential propagates, then more calcium is going to come in to the fiber than normal, right? Because you've increased the calcium permeability. And the second thing is, again, it looks like the pKa can phosphorylate the ryanodine receptors on the SR, and let's say that it causes more of them to be open or puts them into a more open state than they normally would be, right? So more calcium through calcium-induced calcium release actually is able to leave the SR. Cumulatively, what's going to happen? The calcium levels within this ventricular contractile fiber are going to be significantly higher than they normally would be. Under a sympathetic stimulus, under a sympathetic response, ventricular contractile fibers have much more calcium inside of them than they normally would, And we think this is, again, because of the fact that the sympathetic autonomic motor neurons release norepinephrine onto the ventricular contractile fibers. That activates a G protein pathway, cyclic AMP G protein pathway, which increases the amount of pKa inside. pKa causes more calcium channels to be open throughout the plasma membrane. It causes more ryanodine receptors to open, let's say, more easily, or puts them into a more open state. And both of these things are going to translate into more calcium being located in the intracellular fluid than normal under a sympathetic response within these ventricular contractile fibers. And if there's more calcium inside than normal, what's going to happen? There's going to be more calcium available to bind to more troponin. And more tropomyosin will unwind off of actin, right? And that will enable more myosin heads to bind to more actin. And what will happen? The contractile fiber will generate more force. We know for sure, the mechanisms aren't perfectly clear, but we know for sure that under a sympathetic response, under a sympathetic stimulus, ventricular contractile fibers generate more force. We know it. Nobody debates this, okay? The sympathetic nervous system causes the right and left ventricle to generate more forceful contractions. The fibers themselves generate more force. And this is one of the predominant theories revolving around how that's possible. The idea is the sympathetic nervous system causes, basically calcium levels to elevate to greater degrees inside of the ventricular contractile fibers. And then more calcium combined to more troponin, exposing basically more actin, more myosin binding sites on all of the different, G globular actins, and that enables more myosin and actin to interact, and the ventricular contractile fibers generate more force because of this. Now, there are other things, I won't ask you this on the exam, but there are other things that can happen, theoretical things, like, this is all theoretical, but let's say more theoretical. Some people believe that pKa or another actual second messenger actually influence the myosin heads to be able to interact more efficiently with actin, which also could result in more force production. Certainly, we know that pKa influences the circupumps so that more calcium is pumped back into the SR, and that actually results in a faster relaxation, which you need for a faster heart rate. Because if heart rate is faster, like if you have a more frequent heart rate, right, then you also need relaxation to happen faster. And we know that the sympathetic stimulus causes these ventricular fibers to also relax faster. They pump the calcium back into their SR and back out into the extracellular fluid at a faster rate as well. Because if they release more of it, they also need to get more back into the SR and out into the extracellular fluid. So there's a whole, conglomerate of confusing things that the sympathetic nervous system does to contractile fibers of the heart. But one thing that we're confident about is that it causes contractile fibers of the heart. And this includes the atrial fibers as well, but it's less significant and important. It causes contractile fibers of the heart to generate more force. That's what the sympathetic nervous system does. So then you have to think about what this means on a functional level. Okay, so when the sympathetic nervous system is activated, right, during physical activity, stressful activity, whatever it is, when the sympathetic nervous system is activated, it's going to do two things, really, right? The sympathetic autonomic motor neurons are going to release norepinephrine onto the sinoatrial node, and they're going to release norepinephrine onto ventricular contractile fibers. By releasing norepinephrine onto the sinoatrial node, it's going to cause there to be a greater frequency of action potentials, which means heart rate is going to increase. If the sympathetic nervous system also causes these ventricular contractile fibers to generate more force when they contract, then that means that the left and the right ventricle, we're more interested in the left for the moment, but the left ventricle in particular is going to generate more force. And if the left ventricle generates more force, it's going to pump more blood out with each beat. So stroke volume is going to increase as well. The sympathetic nervous system doesn't just cause heart rate to increase, it also causes stroke volume to increase by making the ventricular contractile fibers generate more force with each contraction, right? Because again, if the ventricular fibers generate more force, then the chamber, which is made up of contractile fibers, is going to generate more force as a whole. And if the chamber generates more force, like the left ventricle, then more blood is going to be pumped up with each beat, which is stroke volume. Let's say stroke volume goes from 70 milliliters to 100 milliliters. And let's say heart rate goes from 70 beats per minute to 120. Look at how much cardiac output is going to increase. And again, this isn't even like high intensity physical activity. Now we're talking about the heart is contracting, heart rate, 120 times per minute. And with each contraction, 100 milliliters of blood is being pumped out of the left ventricle with each beat, right? Stroke volume went way up, right? So not only did heart rate increase, but stroke volume increased. And now you'd have to do 120 beats per minute times 100 milliliters of blood being pumped out of the left ventricle with each beat. And you have an enormous increase in cardiac output, the amount of blood that's circulating around the body per minute. This is what happens during physical activity. During physical activity, and thus during a sympathetic response, and a sympathetic response is happening to prepare you and to allow you to engage in physical activity. During a sympathetic response, to allow for engagement in physical activity, cardiac output goes way up. The amount of blood circulating around your body goes way up. And you can think about this on a real easy level. Why would we want more blood circulating around our body per minute when we're engaging in physical activity? Because what's transported by the blood? Nutrients, for one thing, but mostly oxygen. And what do you want to get more to, of the what do you want to get to the contracting fibers in the body? Because if you engage in physical activity, what are your muscle fibers doing? They're contracting more. Skeletal muscle fibers. Your skeletal muscle fibers are contracting more to engage in physical activity. They're consuming more ATP, so they need to make more ATP. In order to do that, what's one of the main ways that they do that? Through oxidative phosphorylation. They make more ATP within their mitochondria through oxidative phosphorylation. In order to do that, what do they use? Oxygen. What do you need to get more of to the skeletal muscle fibers during physical activity? You need to get more oxygen to them. How do you do that? By bringing more blood to them. So how do you get more blood to them? You increase cardiac output. The whole purpose of pumping more blood around your body during physical activity is to pump more blood and thus oxygen to your contracting skeletal muscles, which need the oxygen to make ATP through oxidative phosphorylation to meet their ATP demands, right? So, that's just some application of this. The main thing that I wanted you to see here was just that the sympathetic nervous system, sympathetic neurons, they don't just increase heart rate, they increase stroke volume. They increase the force that the cardiac muscle fibers generate, and thus the force that the chambers can generate, so thus more blood gets pumped out of the chambers with each beat. So there's one last thing to really kind of discuss here, and that is the sympathetic nervous system is not the only thing that can increase stroke volume. Okay? So the sympathetic nervous system, we know, causes ventricular muscle fibers to generate more force, and thus that means the chambers generate more force, so more blood is pumped out from the chamber with each contraction, something we call stroke volume. Okay? That's not the sympathetic nervous system is not the only thing that can accomplish that. Okay? There's something else called the Frank Starling Law or the Frank Starling mechanism that also can increase stroke volume for kind of the exact same reason. This Frank Starling Law or Frank Starling mechanism, as it can be called, also is going to cause ventricular contractile fibers to generate more force, and thus the chambers of the heart to generate more force so that they pump more blood out with each beat, something that we call stroke volume. Now the question is, what is the Frank Starling mechanism or Frank Starling Law that allows for this? And during physical activity, we know cardiac output increases, clearly. Okay? During physical activity, heart rate increases and stroke volume increases. The number of times that the heart contracts per minute increases. The amount of blood pumped out with each contraction increases. So the amount of blood circulating around the body increases. Now what that also means is that there's also going to be more blood coming back to the heart, right? That has to be true. If you're pumping more blood around the body per minute, you're also bringing more blood back to the heart, right? It's only logical, right? And if more blood is being brought back to the heart than normal, back to the right side of the heart, and that will ultimately end up meaning that more blood is going into all of the chambers than normal, what's going to happen is what's called end diastolic volume is going to increase during physical activity. At least at low to moderate intensities. end diastolic volume will increase. So the overarching principle is, during physical activity, thanks to the sympathetic nervous system, more blood gets pumped around the body per minute than normal. Heart rate and stroke volume increase. If more blood is being pumped around the body per minute than normal, then there's also more blood coming back to the heart than normal. And that means there's more blood filling in the chambers than normal. So what happens during physical activity, again, at least during lower intensity and moderate intensity physical activity, is end diastolic volume actually increases. The amount of blood that's within a chamber at the end of relaxation rises, right? End diastolic volume, and let's just focus on the left ventricle. Left ventricular end diastolic volume increases during, let's say, again, low to moderate physical activity. Why? Because more blood is coming back to the heart than normal. And if more blood is coming back to the heart than normal, then more blood is also filling in the chambers than normal. So at the end of relaxation, at the end of diastole, there's a greater volume of blood in the left ventricle. Okay? So that's the first part of this, is you have to understand during physical activity, if more blood is being pumped around the body than normal, there's also more blood coming back to the heart than normal. And this is causing more blood to fill in the chambers of the heart than normal. So end diastolic volume will rise. Right and left ventricular end diastolic volume will increase. And here's what that means. If end diastolic volume increases, and that means there's more blood in the right and left ventricle than there normally would be at the end of relaxation, then the chambers will stretch more. That only makes sense. If you fill a balloon up with more water, the balloon stretches more, obviously. The same thing applies here. If there's more blood coming back to the heart than normal, and that causes more blood to fill in the chambers than normal, then the chambers will stretch more. The right and left ventricle will stretch more. And what are the right and left ventricle made up of? The right and left ventricle are made up of cardiac muscle fibers. So if the right and left ventricle stretch more because there's more blood filling in them, then the ventricular muscle fibers will stretch more. And this is what we know. If you stretch ventricular muscle fibers more, they generate more force. That's what the Frank Starling Law or the Frank Starling mechanism is. When cardiac muscle fibers, this same thing doesn't apply exactly to skeletal muscle, but it does apply to cardiac muscle fibers. When you stretch cardiac muscle fibers more compared to rest, and by that I mean a typical heart rate of 70 beats per minute. If you stretch them more compared to the amount that they stretch normally at like a heart rate of 70 beats per minute, if you stretch them more than normal, they'll start generating more force. So the question is, why, when you stretch a cardiac muscle fiber more, does it generate more force? We know this happens with an increase in end diastolic volume. During physical activity, more blood comes back to the heart than normal, and that causes more blood to fill in the chambers than normal, and thus the chambers stretch, causing the cardiac muscle fibers that make up the chambers to stretch more, and the cardiac muscle fibers start generating more force. But the question is why? And there used to be this old belief that I'll show you in just a second that no one really believes anymore. The old belief was that the sarcomeres within cardiac muscle fibers were just naturally overly shortened. Okay, so there was double overlap of the actin filaments, and thus in this whole central region of the sarcomeres, myosin and actin could not interact, and force could not be generated maximally. So if you could take the cardiac muscle fiber and stretch it out, right? What's the cardiac muscle fiber made up of? The cardiac muscle fiber is made up of myofibrils, which are made up of sarcomeres. So if you stretch the cardiac muscle fiber out, you're going to stretch the myofibrils out, which is what the cardiac muscle fiber is made up of. And you're going to stretch the sarcomeres out because that's what the myofibrils are made up of. And if you stretch the sarcomeres out, you would remove the double overlap. You would remove the double overlap of the overly shortened cardiac sarcomeres, and more myosin and actin would be able to interact, and this would allow for greater force production. This is probably something, honestly, you're going to continue to learn for a while. If you go to any sort of healthcare related program, again, nursing school, PA, medical, whatever, physical therapy, go down. I'm not trying intentionally to leave anybody out. Probably wouldn't learn about this as much as something like dental school, but you might. Okay, so this is probably what you'll learn, I would guess. But we've known for like 10 years or more that this really is not true. It was a great theory. It was actually Frank Starling's theory. This is what he believed at the time. And again, we didn't have technique. This was discovered a long time ago, in scientific terms at least, like 100 years ago. So maybe a little bit, 70, 80 years ago. Anyways, we didn't have techniques back then like we do now, technology, and this was you know, the predominant theory. Might actually be more like 50 years ago. I'm just thinking out loud. Anyways, the theory was just simply that cardiac sarcomeres, right? Cardiac muscle sarcomeres, they were just naturally overly shortened. You know, like when your heart's beating at 70, you know, contractions per minute. The sarcomeres within the cardiac muscle fibers are just kind of overly shortened. And if you were to take those cardiac muscle fibers and you were to stretch them out, like what happens when end diastolic volume increases, then you would remove the fact that you would remove this double overlap. You would remove the fact, you would get rid of the fact that the sarcomeres were overly shortened, right? Because you would stretch out the muscle fibers, the cardiac muscle fibers, and thus the sarcomeres. And this would enable for more myosin and actin to interact because you wouldn't have that double overlap anymore. And this was the explanation for how greater force production happened. Now, the funny part of this conversation is that we kind of know that this isn't true. We know that cardiac muscle fibers don't have overly shortened sarcomeres at, you know, kind of a resting heart rate. But we also don't know exactly what the explanation is as to why they generate more force when they're stretched. I would say the two best going theories at the moment are, you know, one, for some reason, when you stretch a cardiac muscle fiber, it increases its calcium sensitivity. Meaning like, perhaps when you stretch the cardiac muscle fiber, maybe for some reason, troponin has an increased calcium sensitivity and it binds calcium to a greater degree. Maybe when you stretch the cardiac sarcomere, the stretching of the cardiac sarcomere might open up calcium channels in the plasma membrane, which would allow more calcium in, which would then bind to more troponin. Right? There's another possibility. There's also theories about the three-dimensional structure of the actual cardiac muscle fiber, and if you stretch it out, it puts the kind of myosin and actin filaments into a more kind of optimal orientation, not related to their length, but more so due to the kind of lattice structure of the muscle fiber itself. I would say increased calcium sensitivity or increased intracellular calcium levels are the two go-to theories at the moment, but they very well could be wrong. Okay, so the idea would be if you take a cardiac muscle fiber and you stretch it out, maybe troponin increases its sensitivity to calcium, meaning that it binds calcium more easily, which would unwind more tropomyosin and allow more myosin and actin to interact. or maybe when you stretch the fiber out, it allows more calcium to come into the fiber, which would bind to more troponin and allow more myosin and actin to interact. Both of those would explain why more force would be produced, but there's really not great scientific evidence to support that either of those are true. All I can promise you is on an exam, overly shortened sarcomeres being stretched out and thus that allowing more force to be produced, that would not be the right answer for how cardiac muscle fibers generate more force when they're stretched. This right here that we just went over, that would be wrong. This we're really confident is not right. Okay, stretching of the cardiac sarcomeres doesn't remove overly shortened sarcomeres and double overlap. That's not the explanation for greater force production. It's something else, probably something related to calcium. The big takeaway from all of this, though, is that stroke volume during physical activity increases for more reason than one. It increases for multiple reasons. During physical activity, one thing that's going to happen is the sympathetic nervous system is going to be more active during physical activity. And that means that sympathetic autonomic motor neurons are going to be releasing norepinephrine onto these ventricular fibers, contractile fibers, and that norepinephrine, for all the mechanisms that we discussed, is going to cause those ventricular fibers to generate more force. And if they generate more force, then the chamber generates more force, pumps more blood out with each beat. That's an increase in stroke volume. The second explanation for why stroke volume increases during physical activity is because more blood is being circulated around the body per minute, and thus more blood is coming back to the heart per minute. If more blood is coming back to the heart per minute, then the chambers are filling with more blood. End diastolic volume is increasing. And when end diastolic volume increases, right, more blood being filled in the chambers than normal, then the chambers and thus the cardiac muscle fibers that make up the chambers stretch more. And when cardiac muscle fibers stretch more due to this increase in end diastolic volume, we know that that causes the cardiac muscle fibers to generate more force, right? And if the cardiac muscle fibers generate more force, that's an increase in stroke volume. If they generate more force, then the chambers will pump more blood out with each beat. What causes that increase in force? Again, hard to know. Maybe stretching the fibers, as I've said a couple times now, may have some influence over intracellular calcium or calcium sensitivity and allows them to generate more force. So during physical activity, you're going to get big increases in heart rate, and you're going to get big increases in stroke volume. The increases in heart rate happen almost exclusively because of the sympathetic nervous system influencing the sinylateral node, and the increases in stroke volume, as we've said, happen for multiple reasons. Increases in the sympathetic nervous system and an increase in end diastolic volume or stretching of the fibers. All of this translates into significant increases in cardiac output during physical activity, the amount of blood circulating around the body per minute. So in the next lecture, and thus the next chapter, we're going to start talking about the vascular system. And when you get to the vascular system, you're going to start seeing something called the afterload, which actually has a negative influence over stroke volume. So there are things that can happen in the human body, and there are things that are happening and do happen all the time that actually negatively influence stroke volume. They can decrease stroke volume. So my point is, we're about to start talking about the vascular system, and you're going to see components of the vascular system, physiological aspects of the vascular system that can negatively influence the amount of blood that gets ejected out of the heart.